Good day. Topic of today's lecture is glaucoma. First of all, we should start from definition of glaucoma. The term glaucoma covers several diseases with differing etiologies that share the common finding of optic neuropathy with characteristic pathologic finding in the optic nerve head and a specific pattern of visual field defects. The disease is often but not always associated with increased intraocular pressure. The final stage of glaucoma is blindness. Physiology of aqueous humor circulation. Aqueous humor is produced from plasma by the ciliary epithelium of the ciliary body, pars plicata, using a combination of active and passive secretion. The average normal intraocular pressure is 16-26 millimeters of hydrargyrum in adults, is significantly higher than the average tissue pressure in almost every other organ in the body. This high pressure is important for optical imaging and helps to ensure uniformly smooth curvature of the surface of the cornea and constant distance between the cornea, lens, and retina. The aqueous humor is formed by the ciliary process and secreted into the posterior chamber of the eye. And the aqueous humor passes through the pupil into the anterior chamber. Through the pupil and from where it exits the eye via three routes. It may be trabecular outflow, 19% aqueous flows through the trabeculum into the Schlemm canal, and then the episcleral vein. This is a bulk floor pressure sensitive route, so that increasing intraocular pressure will increase outflow. Second one is uvascleral drainage, is 10% aqueous passes across the face of the ciliary body into the suprachoroidal space and is drained by the venous circulation in the ciliary body, choroid and sclera. And this slide you can see the aqueous humor outflow. That's about it. And measuring of intraocular pressure, first palpation. Palpation is comparative palpation of both eyeballs, is a preliminary examination that can detect increased intraocular pressure, just increased or decreased. If the examiner can indent the eyeball which fluctuates under palpation, pressure is less than 20 millimeters of hydrargyrum. An eyeball that is not resilient but rock hard is sign of about 16-17 millimeter of hydrargyrum of pressure. It may be in acute angle closed glaucoma. And next one is Schwartz tonometry. Applanation tonometry. Applanation tonometry is Schwartz, Goldman's tonometry, and Draeger method. And this one, Goldman applanation tonometry on this slide. And this, I talk about this gonioscopy later. Next one, classification of glaucoma. Glaucoma divided into congenital and acquired. Types of congenital, we're talking about types of congenital glaucoma later. Now we are talking about acquired glaucoma. And acquired glaucoma divided into two, primary and secondary. Primary glaucoma divided into open angle and closed angle glaucoma, and secondary glaucoma. Primary open angle glaucoma, primary open angle glaucoma begins in the middle aged and elderly patient with minimal symptoms that progressively worsen. The angle of the anterior chamber characteristically remains open throughout the clinical course of the disorders. Etiology, the cause of primary open-angle glaucoma is not known, although it's known that drainage of the aqueous humor is impeded. The primary lesion occurs in the neuroretinal tissue of the optic nerve as compression neuropathy of the optic nerve. And in primary open-angle glaucoma, intraocular pressure may be more than 21, glaucomatous optic nerve damage, and open anterior chamber angle, and examination of anterior chamber is gonioscopy. Next one, characteristic visual field loss as damage progresses, and absence of signs of secondary glaucoma or non-glaucomatous cause for the optic neuropathy. And risk factors, it may be age. We said race, it's significantly, perhaps, for example, for more common develops at an earlier age and may be more difficult to control in Black individuals than in whites. Family history, diabetes mellitus, myopia, contraceptive pill, vascular diseases, translaminar pressure gradient, and ocular perfusion pressure. The symptoms of open-angle glaucoma, the majority of patients with primary open-angle glaucoma don't experience any subjective symptoms for years, and is dangerous because we said about total stage is total final stage of glaucoma. It's maybe blindness. A small number of patients experience occasional unspecific symptoms such as a headache, a burning sensation in the eye, or blurred or decreased vision that the patient may attribute to a lack of eyeglasses or insufficient correction. The patient may also perceive rings of color around light sources at night, which has traditionally been regarded as a symptom of angle-closed glaucoma. Primary open-angle glaucoma can be far advanced before the patient notices an extensive visual field defect in one or both eyes. It's crucial to diagnose the disorders as early as possible because the prognosis for glaucoma detected in its early stage is far better than for advanced glaucoma. Where increased intraocular pressure remains undiagnosed or untreated for years, glaucomatous optic nerve damage and the associated visual field defects will increase to the point of blindness. Diagnostic consideration, measurement of intraocular pressure, of course, first. Next one, 24-hour intraocular pressure test, gonioscopy, it's examination of angle of anterior chamber. Ophthalmoscopy, this condition of glaucoma. You can see excavation of cupping of glaucoma, cupping of optic nerve. And treatment divided into medical treatment and surgical. Medical treatment includes drops and indication for initiating treatment and glaucomatous changes in the optic cup. Medical treatment should be initiated where there are signs of glaucomatous changes in the optic cup or when there is a difference of more than 20% between the optic cups for 2 eyes. Any intraocular pressure exceeding 25 millimeters of hydrargium should be treated. Increasing glaucomatous changes in the optic cup or increasing visual field defects in spite of anti-glaucomatous medication. And this came to of medical therapy. It's topical eye drops. First, it's maybe parasympathetic agents. It's maybe cholinergic agents. It's pilocarpine, indirect cholinesterase inhibitors, and prostaglandin analogs, sympathomimetic agents, sympatholytic agents, and carbonic anhydrase inhibitors. And surgical treatment of primary open-angle glaucoma includes indication for surgical treatment. Its medical therapy is inadequate. The patient doesn't tolerate medical therapy. Reaction includes such allergy, reduced vision due to narrowing of the pupil, pain and ciliary spasm, and ptosis. The patient isn't a suitable candidate for medical therapy due to a lack of compliance. Surgical treatments, there are argon laser trabeculoplasty, filtration surgery, and cyclodialysis. On this slide, you can see technique of argon laser trabeculoplasty, this technique of filtration surgery, and prophylaxis of glaucoma. No prophylactic action can be taken to prevent primary open-angle glaucoma. Early diagnosis is crucial and can only be made by an ophthalmologist. By the age of 40 at the latest, patients should have their intraocular pressure measured regularly. And prognosis, the prognosis depends greatly on the stage at which primary open-angle glaucoma is diagnosed. As a general rule, therapy is more effective the earlier it can be initiated. Next one, primary angle closure glaucoma. Definition of angle closure glaucoma: acute episodic increase in intraocular pressure to several times the normal value due to sudden blockage of aqueous outflow by close or narrower angle of the anterior chamber. Production of aqueous humor and trabecular resistance are normal. Etiology: eyes anatomically predisposed to develop primary angle closure glaucoma includes hypermetropic eyes with shallow anterior chamber. Next one, this pupillary block increases the pressure in the posterior chamber. Next one, the pressure displaces the iris anteriorly toward the trabecular meshwork, suddenly blocking the outflow of aqueous humor. Symptoms: acute onset of intense pain. The elevated intraocular pressure acts on the corneal nerves to cause dull pain. This pain may be referred to the temples, back of the head, and jaws via the 3 branches of the trigeminal nerve. Maybe vomiting occur due to irritation of the vagus nerve and can simulate abdominal disorders. The generalized symptoms such as headache, vomiting, and may be dominant to the extent that the patient fails to notice the local symptoms. Diagnostic consideration. The diagnosis is made on the basis of a triad symptoms: unilateral red eye with conjunctival or ciliary injection, fixed and dilated pupil, hard eyeball on palpation. Treatment. An acute glaucoma attack is emergency and the patient requires immediate treatment by an ophthalmologist. The underlying causes of the disorders require surgical treatment. Also, initial therapy is conservative. Medical therapy and the goals of conservative therapy are decrease intraocular pressure, allow the cornea to clear, relieve pain, and types of conservative intraocular pressure reduction within 6 hours surgery the next day, not within 6 hours immediate surgery. Surgical management, it's laser iridotomy, and next one is peripheral iridotomy. Peripheral iridotomy is incisional procedure. And this technique of YAG laser. And on this slide, you can see iridotomy. And secondary glaucoma. Secondary glaucoma, a group of disorders in which rise in intraocular pressure leading to glaucoma is associated with some primary ocular or systemic disease. Classification of secondary glaucoma based on mechanism of intraocular pressure rise, secondary open angle, secondary closed angle glaucoma. And it may be phocogenic, lens-induced glaucoma, pigmentary glaucoma, neovascular glaucoma, inflammatory glaucoma, traumatic glaucoma, steroid-induced glaucoma, pseudoexfoliative glaucoma, glaucomas associated with intraocular tumors. Phacomorphic glaucoma, it's when you see this phacomorphic glaucoma, a medical treatment, control of intraocular pressure by mannitol, systemic acetazolamide, and first aid is surgical treatment, cataract extraction. This one, pigmentary glaucoma. Next one, neovascular glaucoma. Shortly about secondary glaucoma. Inflammatory glaucoma, non-specific inflammatory glaucoma. It may be open angle and closed angle, and it's maybe due to uveitis. Traumatic glaucoma. Steroid-induced glaucoma. And next type of glaucoma, it's congenital glaucoma. Condition of raised intraocular pressure in early childhood with developmental anomaly of the anterior chamber angle region without any associated abnormality of eye or adnexa, which obstructs the drainage of aqueous humor. It appears between birth and 4 years of age. Both eyes are usually involved, but to varying severity. Boys are more affected than girls. Affects 1 in 10,000 births. Etiology, hereditary factor is occasionally present. Types of congenital glaucoma: primary, developmental glaucoma with associated ocular anomalies, and secondary congenital or juvenile glaucoma. It may be abnormal development of the anterior chamber angle and trabecular meshwork during outer development. It may be trabecular dysgenesis. Angle develops from mesodermal tissue. Clinical presentation symptoms: photophobia, blepharospasm, lacrimation. Signs: enlargement of the globe, obophthalmos, is a result of elevated intraocular pressure. Bluish discoloration patches over sclera. Clinical signs: corneal edema, corneal enlargement, tears and breaks in distal membrane. On these sides you can see epiphora, corneal edema, high iris insertion on gonioscopy, and breaks of distal membrane. Signs: anterior chamber becomes deep. Iris may show iridogenesis and atrophic patches in the late stage. Lens becomes flat due to stretching or zonals and may even subluxate. Intraocular pressure is raised. Diagnosis in clinical clues: enlarged eye tearing and photophobia. Often babies also rub their eyes. Measurement of intraocular pressure, ophthalmoscopic, gonioscopic examination, corneal diameter. And treatment of congenital glaucoma is goniotomy, trabeculotomy, or it may be trabeculotomy and trabeculopectomy.